Today we're going to be talking about diet and coronary heart disease. This presentation will reflect the epidemiologic evidence and related hypotheses of diet to disease. The classic diet-heart hypothesis has been influenced by two forms of epidemiologic support, one being ecologic correlation studies and the second being migrant studies. Ecologic and migrant studies have been correlated to dietary factors of serum cholesterol. Though these studies have been correlated with dietary factors associated with the development of serum cholesterol, they do not primarily address the relationship between diet and heart disease. Ecologic studies convey the relationship between diet to the rate of heart disease, while migrant studies serve as descriptive studies. Originally, it was thought that there was a direct correlation between the cholesterol consumed and a patient's levels of cholesterol in their blood, plaque, and clinical complications. In the second part of the last century, it was found that dietary cholesterol only played a minor role in regulating serum cholesterol levels. Fatty acids were found to be a major determinant of serum cholesterol. These fall in line with the reasons that a Mediterranean diet would have been found to reduce the risk of mortality due to heart disease. A traditional Mediterranean diet typically consists of non-refined cereals and grain products such as whole grain bread or brown rice, 2 to 3 servings of vegetables per day, 6 servings of fruit per day, 1 to 2 servings of dairy products per day, and olive oil as the main added fat. Fish is consumed 4 to 5 servings per week, and poultry, olives or nuts, and potatoes, eggs, or sweets should be consumed about 3 to 4 servings of each per week. Red meat and other meat products are typically only consumed 4 to 5 times per month. Through the passing of time, the relationships between diet and coronary heart disease have proved to be difficult to assess due to the vast array of confounding and coinciding influential variables, as well as biological variables and heterogeneity of food consumptions amongst populations. This is where migrant studies become an invaluable resource in epidemiology. Here we have a study by Kato and his colleagues illuminating the correlation between the saturated fat intake of Japanese individuals living in Japan, Hawaii, and San Francisco, and the incidence of coronary heart disease. Studies such as this, where individuals with similar genetic backgrounds are assessed in different environments, strengthens the correlation between coronary heart disease and environment rather than genetics. Ecological studies comparing different populations are also quite beneficial in epidemiological studies. These studies aid in tackling the complications presented by a lack of variety in food consumption amongst the same population. Here, Keyes compared the 16 different populations in 7 different countries and presented data indicating that countries with higher percentage of saturated fat consumption also had a higher incidence of coronary heart disease. Studies utilizing questionnaires can also provide insight on correlations between diet and disease, as you can see here with the Nurses' Health Study. In contrast, the results of this study stress the relationship between trans fatty acids and the coronary heart disease. Studies such as case control studies that are retrospective are harder to conduct and draw valuable conclusions from due to lack of controlled variables as well as recall bias. Due to the unique population in Costa Rica, in which most members have access to the same healthcare and are eager to participate in studies, case control studies have been successfully conducted on this population. The present study found a positive correlation between palm oil, which is a saturated fat, and coronary heart disease. Biomarkers such as plasma lipid fractions, platelet, blood, or subcutaneous fat provide valid information about fatty acids in the diet, which are hard to obtain from questionnaires. Several studies, such as the Physicians' Health Study and Nurses' Health Study, examined whole body and trans fatty acids as a risk factor for coronary heart disease. The limitation is fatty acids are affected by other dietary intakes, such as endogenous production or weak correlation with fatty acid intake and metabolism. Randomized trials are the most direct test to determine whether changes in dietary lipids can reduce the risk of coronary heart disease. In the multiple risk factor intervention trial, it was noted that fat reduction had minimal effect on serum total cholesterol levels, but those that substituted unsaturated fat for saturated fats, both serum cholesterol and coronary heart disease incidence were reduced. Although intervention trials have contributed vital support to the diet heart hypotheses, a randomized trial of primary prevention among a free-living population has not been done and may never be conducted. Applications of nutritional epidemiology research can play an important role in the realm of policy making by developing the evidence for the link between diet and disease. Policy making is complex, however, because it is so greatly influenced by economic interests and political agendas. Decision-making is reliant upon a high level of certainty, which can be derived from a combination of findings from observational studies and short-term randomized trials. Coronary heart disease is one of the major leading causes of death in the United States, and epidemiological studies have proven again and again that it is largely due to environmental factors rather than genetic fate. In other words, our diets can play a major role in preventing or promoting onset of coronary heart disease and other related disorders. Currently, the most topical dietary components in the realm of policymaking are trans fats, sodium, and sugar-sweetened beverages. Data from observational studies, along with short-term randomized trials, have demonstrated its adverse effects and has proven sufficient evidence for policy actions. Trans fats has been banned from Denmark, Brazil, and Chile, several major cities in the United States, and also in California and Puerto Rico. Sodium at great intakes has been shown to increase blood pressure and is positively associated with coronary heart disease. This is an example of the benefit of food labeling because nutrition facts are required on foods and beverages. This offers a level of transparency in the ingredients and contents of packaged foods, which is important for someone who is watching their sodium intake. Finland has had success in using a multifaceted approach of education, labeling, and cooperation with the food industry to reduce sodium amounts. Their collective salt intake has decreased by approximately 25% between 1979 and 2002. It is also important to mention the impact of sugar-sweetened beverages, which are positively associated with coronary heart disease, obesity, type 2 diabetes, and gout. Campaigns for implementing a tax policy on sugar-sweetened beverages are occurring in the U.S. and Mexico, and statistical modeling analysis suggested that a 20% increase in the prices of those beverages would reduce consumption by 11 to 13%. Research establishes the trends, agriculture, the social and economic status, and biological relationships of the population with the intended or unintended health outcome in order to implement policy. The AHA/ASA develops science-based policy advocacy materials every year to propose to government officials, legislation, and regulatory agencies in order to maintain their mission to decrease disability and death from heart disease and stroke. Nutrition and diet influence the risk for coronary heart disease. The SNAP program provides monetary assistance to low-income families to purchase food and beverages, but does not provide education or incentives to choose healthy foods or to avoid high-fat, high-sodium foods or sugary beverages affecting health outcomes. The WIC program has shown to be an effective tool to promote health and is cost-effective. It provides nutritional counseling as well as vouchers that provide participants with higher nutritional foods. The breakfast and lunch programs have had mixed results. Even though there have been considerable efforts to implement better standards, children are still consuming higher saturated fat and sodium levels. Limited resources and political pressure to undercut spending have been significant in limiting the quality of food. Thank you for taking time to listen to our presentation, and I hope that all your questions have been answered through our slides.